Well, welcome to the Sleep 2023 conference in Indianapolis. We're here at the Somnix booth with Dr. Lennon. Welcome.
Thank you so much. Pleasure to be here.
Dr. Lennon has been an advisor to Somnix for a number of years and has been working on a lot of alternatives to CPAP for OSA treatment.
Correct.
So, Dr. Lennon, my first question to you is about the show. This is day 4 of the show, and have you seen new treatment or new ideas on specifically the OSA treatment that's been discussed and presented during the show?
Yeah, there's been a lot of interesting talk on sleep apnea. Of course, it's the most common sleep disorder that we see. Most of the new stuff on sleep apnea really has to do with the diagnostic side of using things like artificial intelligence to try to use simpler sensors to make the diagnosis in the first place. Just this morning, there was a very interesting session on using drug therapy for all sorts of different sleep disorders, including for sleep apnea. So this is a very interesting topic of, how can we use pharmacology to improve the upper airway, to improve hypoxia, to improve the respiratory drive, to lower the AHI, improve outcomes for people that have sleep apnea. Now, there's a lot of different drugs that have been tested, looking at a lot of different mechanisms. The bottom line is it's all really preliminary. So there's some promise that drug therapy might have a role in treatment of sleep apnea. We're probably still at least a decade away from having a really viable solution for someone to just swallow a pill and have their sleep apnea adequately treated.
That would be great, but we're not there yet.
Not for a while.
So, talking about all those different alternatives to CPAP, because you have a lot of experience, what would be your best advice to a sleep physician who has a lot of experience with CPAP but now wants to help their patient with those alternative treatment and doesn't know anything about them? So, what would be their first move and their first approach to navigating that kind of world of those alternative treatments?
I'd say the first thing to do is really just do your homework and find out what are these treatments, what do they do, what do they don't do. Because it's really important if a patient is being started on a therapy, they're going to have questions, they're going to run into hurdles, they're going to have some difficulty with it. And so it's important for the prescriber to have some degree of understanding of what that therapy is to help the patient overcome any of these initial hurdles. Whether it's logistics, whether it's cost, whether it's comfort, whether it's utilization, or whether it's efficacy, the provider has to be the expert on that treatment to help guide the patient through that therapy.
Okay, very well. Now, you do mention that it's important to guide the patient. How important is actually the patient point of view and preference in the choice of the alternative treatment? Because the obstructive sleep apnea is a chronic disease. By definition, the patient has to be treated every night. Therefore, the patient has to like the treatment. Tolerate is not enough.
That's right.
Therefore, how do you interact with the patient and how do you take into consideration their own preference in deciding what best treatment would work for them?
Yeah, the patient acceptability really is paramount. If the patient is not accepting the therapy, as you said, not just tolerating, but actually willing to use it on a regular basis, it's just not going to work for them. We know that in the short run, a little over 2/3 of patients are going to be accepting of CPAP therapy, but on timescales longer than a year, it's only about 1/3 of them are going to continue to use that on a regular basis. And so, with all the experience we have with CPAP over several decades, we're still not really able to push that number much higher than 30, 32% or so in the long run. So we want to make sure that when a patient's starting any therapy, whether it's an oral appliance, a surgical intervention, negative airway pressure, or any other therapy, that the patient has a say in it, that they are able to verbalize what they like or what they don't like about any different intervention. And so the provider can take that information in hand and be able to formulate a treatment plan that makes sense for that particular individual. This is not just an embodiment of an AHI. This is a human being with preferences and comforts and discomforts, an entire life history that's going to play a role in whether or not they're going to utilize one therapy or another. And so we want to make sure that we understand the different treatment options that are out there, that we understand the patient in front of us and what their preferences may be, what their comfort levels are going to be, to try to get the best match possible so we can really help to reduce their burden of disease by having a treatment that's not only going to work, but a treatment that's going to work for that individual patient because they're actually able to use it and willing to use it on a regular basis in the long run, not just for one night, not just for 3 months, but for the rest of their lives.
And I'm assuming also toward that goal is that a continuous follow-up of the patient, because as they get treated, as they lose weight maybe, their tolerance to the treatment might change, the performance to the treatment might change as well. So it's also important to have a way, a tool to follow up their performance with the treatment as well.
As you said, sleep apnea is a chronic problem. This is not something that you can just write a prescription and then forget about it. These people do need regular follow-up to make sure that they are using the therapy as prescribed, they're not having any trouble using it at all, and that it continues to work for them. So as you said, the disease state itself can change over time. As we age, our airway becomes less pliable. Our AHI is likely to increase. We're likely to gain weight over time, or perhaps even lose weight over time. So all these different factors can come into play that will actually change the patient's underlying burden of disease, which will therefore require probably some adjustment in their level of therapy. Changing the amount of mandibular movement, changing the amount of pressure they're exposed to, changing drug therapy or position therapy, whatever it might be. As the disease evolves, our treatment needs to evolve with that. And the only way to know is to have regular follow-up with individuals to see where they are right now, and is the treatment that we prescribed way back when, is that still appropriate for them now?
Okay. Well, thank you very much, Dr. Lennon, for stopping by. Hope you have a great rest of the show.
My pleasure. Thank you so much.
Thank you.